Thank you. Dear Chairman, dear colleagues, I'd first like to thank the scientific committee of this Congress for inviting me to share with you the latest news on artificial frozen embryo transfer cycles. These are my disclosures. So let me first show you how important it is for us to try optimizing FET cycles. For many years, the number of ART cycles has substantially increased. And today, we consider that 2 to 4% of all live births are the result of this technique. And in this incredible rise in the use of ART, the number of frozen embryo transfers has significantly increased too, and this was the result of huge improvements in cryopreservation techniques, but also the expansion of elective single embryo transfers and freeze-all strategies. So for instance, you can see in this graph that up to 40% of ART live birth results from a FET cycle. So this is definitely a burning issue for us to try optimizing these FET cycles. There are several methods to prepare the endometrium for implantation, and you know that none has stood out as being superior to the others in terms of the live birth rates. So for many years, clinicians have been chosen the most convenient one, which was the artificial cycle, consisting in the administration of exogenous estradiol and progesterone, because it reduces monitoring requirements and allows the day of the FET to be chosen. A good illustration of that is this British survey from 2018. When you asked the British clinicians about their standard method to prepare the endometrium, even in ovulatory women, the majority answered artificial cycle. But this is changing, we will see. So my job was to give you an update on artificial FET, and I've chosen to address 3 topics: progesterone levels, estradiol levels, and obstetrical and perinatal outcomes. So let's start with progesterone, which is always in the spotlight because it's recognized as the key hormone of the luteal phase, involved in implantation and the maintenance of pregnancy. You know that in artificial cycles lacking a corpus luteum, the addition of exogenous progesterone is a crucial step to mimic the mid-cycle shift to the secretory phase and to synchronize the endometrium with the embryo's developmental stage. And we have different types of progesterone, natural or synthetic, different mode of administration, and today we don't know the optimal protocol to give this progesterone. So we used to give the same treatment to every patient, but hopefully in a recent trend toward individualizing progesterone supplementation, we've started monitoring serum progesterone levels around the time of the FET. And as you can see in the results of this meta-analysis, gathering results from observational studies, the serum progesterone level around the time of the FET seem to correlate with clinical outcomes. And if you look at a cycle using vaginal progesterone, the critical threshold below which live birth rates are decreased and miscarriage rates are increased seems to lie around 10 nanogram per milliliter. But we have the first difficulty is that there's no validated cutoff. And this is because serum progesterone levels are influenced by a variety of factors. If you consider different types of progesterone administration, you don't have the same serum level. If you use different immunoassays, or eventually if you measure it at different timing around the FET, or even in the same day, it depends on the time interval between last dose administration and the blood testing. So first step when you wanted to tailor progesterone administration is to ideally determine your own cutoff in your daily clinical practice. So that's what we did a few years ago. We looked at serum progesterone levels on the day of a blastocyst FET in patients receiving 600 milligrams per day of micronized vaginal progesterone. And we found a cutoff of 9.8 nanogram per milliliter, in below which our patients with low progesterone, here in blue bar, had higher early miscarriage rates and lower live birth rate. So this was in accordance with the literature. So interesting tool to measure progesterone, but is it reliable? We wondered about its reproducibility. So let me show you results from a very recently published paper. We compared the serum progesterone level in more than 2,050 patients who underwent 2 consecutive FET in artificial cycle with exactly the same luteal phase support and same conditions for progesterone measurement. And we found that there was no significant intra-individual variability between FET1 and 2, considering progesterone levels. And hopefully, less than 20% of the patients had discordant progesterone levels, meaning one result below and one result above our cutoff. So pretty reproducible. The next step when you want to monitor progesterone was to try understanding why patients receiving the same treatment and having the same conditions of progesterone measurement displayed such progesterone levels disparities. So we tried to work on clinical factors associated with low serum progesterone levels to try understand which subgroup of patients could benefit from individualizing this supplementation. And what we found was that BMI, a higher BMI, and also a higher parity rank were associated with significantly lower progesterone levels. So BMI, it was in accordance with other published studies, but what was pretty new was parity and also the non-European geographic origin. So with this factor, you seem to have lower progesterone levels. What about specific gynecological disease? For instance, endometriosis. You all know that there's progesterone resistance described in the endometrium of endometriosis patients. So we may wonder if endometriosis patients would benefit from higher progesterone levels to conceive. So we compared in our experience the serum progesterone levels in patients who were pregnant after an artificial FET cycle, according to the presence or absence of an endometriosis and adenomyosis. And as you can see in the graph, we found no significant difference between progesterone levels in endometriosis patients and controls, and the same for adenomyosis. So maybe this progesterone resistance is not relevant at a clinical level. Well, last step was to try individualizing progesterone supplementation to restore satisfying reproductive outcomes in patients with low progesterone, if possible, in the same cycle. So there are only few studies, observational. Most of them, Spanish studies, worked on adding subcutaneous progesterone the day before or on the evening of the FET, and they found interesting results. As you can see here in orange bars, patients who had a rescue reached similar outcomes as patients in blue bars with initially high progesterone levels. And the conclusion of this recent meta-analysis about individualized LPS was that changing the route of administration of progesterone seems the best way to reach satisfying reproductive outcomes, whereas when you just increase the dose of vaginal progesterone, it doesn't seem to be efficient. So maybe there's an absorption issue. When you reach a certain level with vaginal progesterone, you have to add another route of progesterone. So what about dydrogesterone? Because it has recently been in the spotlight. Well, we only have very scarce data, observational too. This Belgian study has found interesting results. Maybe when you add dydrogesterone on the day of the FET, you can restore good live birth rates in patients with low progesterone levels. But I have two concerns with dydrogesterone, so that's why we don't use it in our clinical practice. The first one is that we have no routine measurement available for dydrogesterone level. So we are in the era of individualizing progesterone by monitoring the levels, but with dydro you can't do it because we have no routine techniques. And what was interesting in this work from Professor Griesinger's team is that they managed to monitor dydrogesterone level in artificial FET using only dydrogesterone as luteal phase support. As you can see in this graph, there was a lot of intra and inter-individual variability in dydro levels between different FET cycles. And some patients, about 25% of the patients, had dydrogesterone levels below a threshold and therefore lower ongoing pregnancy rates. So with dydrogesterone, even 30 milligrams per day, you have some absorption issue and it may not be the optimal dose for every patient. But my main concern is about safety, because you've probably heard about retrospective study highlighting a higher risk of birth defects in patients, in children born after dydrogesterone exposure in early pregnancy. So we decided to perform a pharmacovigilance study, which is called a case-non-case study. You compare the risk of birth defect reports with dydrogesterone or any other drug, and we used an international pharmacovigilance database and found a 5-time higher risk of birth defects with dydrogesterone compared to any other drug, any other ART drug, but also compared with progesterone. So maybe we need to be cautious before giving dydrogesterone to all our patients to replace vaginal progesterone. Well, I'm done with progesterone. Let's talk about estradiol, because we need to prime the endometrium with estradiol before progesterone, and its role has long been underestimated. So I was glad to read 2 days ago this interesting review in Human Reproduction Update about the pathophysiological role of estradiol in the early stages of pregnancy. And the key message was that low estradiol is associated with non-conceiving cycle, but also excessive estradiol exposure may lead to lower live birth rate and also adverse obstetrical outcomes such as preeclampsia. And we have no clue of the optimal protocol to give estradiol in artificial FET cycle. So it's an important field to work on. We already had a feeling that estradiol was important because a few years ago we studied the duration of estradiol exposure prior to the FET and found that patients who received more than 28 days of estradiol before the frozen embryo transfer had higher miscarriage rates, here in red, and lower live birth rates. So too long estradiol is too toxic. What about too high? Do we have some clues in FET cycle? Well, some teams have started monitoring estradiol levels as we did for progesterone, and results are controversial, but the majority seems to highlight the detrimental role of high estradiol levels around the time of the FET on clinical outcomes. So we looked at our data. and studied more than 2,000 cycles of blastocyst artificial FET cycles using transdermal estradiol. We measured estradiol on the day of the FET, and as you can see here in gray, the patients with higher estradiol levels, more than 300 picogram per milliliter, had a higher early miscarriage rate. We did not reach significance with the live birth rate, but there's a tendency towards a decline in the live birth rate with increasing estradiol levels. We may even go further because we know that estradiol may be toxic for implantation, but what about placentation and adverse obstetrical outcome? We already know from fresh embryo transfer cycles that high estradiol levels are associated with a higher risk of preterm birth and low birth weight. So do we have data on artificial FET? Very scarce, but I found this Chinese study. They measured estradiol at the 5th gestational week, so before the luteal-placental shift, in artificial FET cycles, and patients were compared according to their estradiol level and the risk of preeclampsia, and they found that patients who had higher estradiol levels at the beginning of the pregnancy had a higher risk of preeclampsia, even after adjusting for several confounding factors. So maybe estradiol has something to do with adverse obstetrical outcomes, which leads to the last part of the talk. We all know now that artificial FET cycles are associated with an increased risk of adverse outcomes if we compare it to ovulatory FET cycles. So what we know from recent meta-analysis is that you have a higher risk of large babies, but also hypertensive disorders and preeclampsia, and maybe postpartum hemorrhage and placenta previa or accreta spectrum disorders. What magnitude of risk are we talking about? When you compare natural FET cycle and artificial FET cycle, it seems that there's a 2 to 3 times higher risk of developing preeclampsia or of having a large baby. It's less clear for placenta accreta, but maybe the same range of risk. Do we know the phenotype of these preeclampsia? Well, not much. It seems that it may be about a risk of late onset preeclampsia and not early onset, but really this needs to be investigated. There are some Chinese data showing that late onset preeclampsia were increased in artificial cycles compared with natural cycles and fresh cycles, about 2 times higher, and not early onset, which may be a little bit reassuring, but this needs to be worked on. A final question, why are these outcomes increased in artificial FET compared with other FET cycles? Well, we don't know, but there are appealing hypotheses, so I urge you to read 2 recent papers from Conrad and colleagues who have worked a lot about that. They propose shared etiologies for the different adverse outcomes we've talked about. First thing may be that there is a suboptimal endometrial preparation with our exogenous treatments. So if you have inadequate estradiol and or progesterone supplementation, and this may be in terms of dose, route, timing, levels, this leads to impaired desideralization, and it is probably a problem of greater than normal trophoblast invasion, meaning this leads to robust placenta, larger than normal. So larger placenta leads to larger babies. So this accounts for the risk of macrosomia. And then they think that while pregnancy develops, these large babies and placenta leads to placental ischemia, which may contribute to late onset or term preeclampsia. Another factor is probably the lack of corpus luteum factors, such as relaxin, because we know these factors also impact decidualization and also contribute usually to maternal vascular adaptation in early pregnancy. So this may also contribute to the onset of term preeclampsia. Let me conclude. If we look back at the survey I've shown at the beginning of the lecture, with the majority of artificial FET, now, no doubt it will change if we ask clinicians, and we would certainly have a majority of ovulatory FET cycles, but yet we will always need to use artificial FET cycles because we have anovulatory patients such as POI or PCOS patients, which are very hard to stimulate. So we should not abandon working on these cycles, and we should try better improve our understanding so as to optimize efficacy and safety. And we've started doing this by monitoring progesterone and individualizing its supplementation. But there's a lot of work to do about estradiol, which is another key hormone for implantation and placentation, and also a lot of work to better understand the pathophysiology of adverse obstetrical outcomes to better prevent the occurrence of preeclampsia and maybe its prevention. Thank you.